Assalamu alaikum. The link clinical consultation day. First scenario, Miss Mona, 35 years old, presented with polyuria. Please take history, examine your patient, and address the concerns.
Good evening. I'm Dr. Musa, Dr. in the clinic today. Let me confirm you are Mrs. Mona, 32 years old.
Yes, doctor.
Okay, Mrs. Mona, brought to my knowledge that you have increase in your water work. So please, could you tell me more about your condition?
Yes, doctor. Actually, I'm not exact. I'm passing water more than usual. This started for me before 3 weeks ago.
So it started since 3 weeks.
Yes.
Any previous attack of this increased water work?
No, this is the first time.
It increasing or decreasing or the same since this 3 weeks?
Yes, every time. Yes, the frequency also increased, doctor.
Frequency and the amount.
Yes, and the amount.
Okay. Do you know how much you pass water work? How much gallons or how much liters?
I'm not sure exactly how much liter, but it's large amount, doctor.
Okay. Any specific time you have this increased water work more at the night or more?
Not related to a specific time.
Did you notice that anything increase your water work, like any exercise or?
No.
Okay. Did you try anything to relieve your symptoms?
No, just I'm trying to drink more water.
So you compensate the water loss. You can compensate that.
Yes, I'm trying, doctor.
You try. Okay. Do you notice any pain during menstruation?
No, doctor.
Do you have any pain, other pain like loin pain or tummy pain?
Yes, doctor. I have mild tummy pain.
Where is the site exactly of this tummy pain?
In upper of my tummy.
Yeah, okay. Ms. Mona, sorry, going back to your urine. Did you notice any gravels during passing urine?
No, doctor.
Any change in the color? Is more white? Any blood in your water work?
No.
Do you think it's frothy?
No.
Did you notice any stone in your water work?
No, doctor.
Okay. Ms. Mona, do you have any fever, increased blood temperature?
No, doctor.
Any history of increased blood temperature in the past?
No.
Okay. Did you feel tiredness? Tired?
No.
Do you notice any lumps or bumps in your body?
No.
Okay. Do you anyone notice that you are pale than before?
No, doctor.
Do you feel any dizziness? You feel yourself dizzy? Okay. Could you tell me more about dizziness? Yes.
Yes, doctor.
Okay, it is dizziness. Could you tell me more about this dizziness? Is it during standing from sitting position or
yes,
with hunger
exactly,
pain?
doctor. Not when I want to change my position from sitting to standing. It happened for me. Doctor, معلش, your voice not clear yet.
Okay, now the voice clear?
Your voice. Yes.
Okay.
Now.
Okay, sorry. Okay, I need to start exactly this dizziness.
Just in this period, doctor, at the same period.
3 weeks also. Okay.
Yeah.
Okay. Do you have any joint pain?
No, doctor.
Any rash in your body?
No.
Or rash in your face?
No, doctor.
Okay. Do you have any back pain?
No.
Okay, going to your tummy pain. You told me the site is in the upper tummy. Could you tell me how much you grade this tummy pain?
3 to 4, doctor.
3 to 4. Okay.
Yeah.
Is it related to moves to any site?
No,
any
doctor.
part of the body? Okay.
No.
What is the nature of this tummy pain? This colicky, dull aching.
Mm-hmm.
Okay. Does this tummy pain specific to any time, more at the morning or after the food?
Not related.
Okay. Do you have any mouth sores?
No.
Any difficulty swallowing?
No.
Any heartburn? Do you feel heartburn or acid brush
No.
from your
No,
mouth?
doctor. No.
Okay. Can I ask you if you have any itching in your body?
No, doctor.
Do you have any yellowish discoloration of your skin or the eye white?
No.
Any shaking of the hands?
No, doctor.
Okay. Miss Mona, do you have any change in your bowel, like loose motion or constipation?
Yes, doctor, I have hard motion.
Hard motion, when it started exactly?
Yes, I started before 2 months ago.
Okay. It is flushable or hard to flush?
Just like hard motion, doctor.
Hard motion. Okay. Any odor, any blood in this in your stool?
No, doctor.
Any bleeding from back passage?
No.
Okay. Miss Mona, do you have any weakness in your body?
No.
Okay. Any numbness?
No.
Did you feel unsteady or fall? Do you have any falls?
No.
Okay. Any problem in your vision?
Yes, doctor.
Okay. What do you mean about vision problem? It is pain or blurring vision or double vision?
Not like that, doctor. Just when I want to see in the road, I have bumping to the object
You are
to
bumping
see the
into-
side. Yeah, difficult to see the side of the road.
I'm sorry for that, Mrs. Mona. Ms. Mona, do you have any headache?
Yes, doctor.
Could you describe me the headache? What is the nature of this headache? Is dull aching?
Yes, dull aching.
It is dull aching. Any side?
All of my head.
All of my head. Okay. How much you grade this headache? 1 is minimum and 10 is maximum. So how much you grade this headache?
4 to 6. 4 to 6, doctor.
Okay. Miss Mona, can I ask you, are you married?
Yes.
Okay. When was the last pregnancy?
Actually, doctor, I'm trying to get pregnant. Yeah.
Okay. Did you use any water woman before?
No, doctor.
Any history of abortion?
No.
Okay. Miss Mona, can I ask you a private question if you don't mind?
Yes, you can.
Okay. What about your intimate relationship?
Actually, doctor, yes, I'm lost the desire. Yeah.
You lose the desire also. Okay. Sorry for that. Miss Mona, did you have any history of blood transfusion?
No.
Any sharing needle, tattoo?
No.
Any piercing?
No.
Okay. Any history of travel recently?
No, doctor.
Okay. Can I ask you, do you have any long-standing disease? Should be aware?
No, doctor.
Okay. Do you have any family history of gland problem or cancer?
I'm not sure, doctor.
Okay. What can I know? What's your medication list?
Just took paracetamol for this headache.
Okay. What do you do for living, Mrs. Mona?
I'm housewife, doctor.
How much it impacted your daily activity, your symptoms?
Yes, it impacted me more.
Sorry for that, Miss Mona. I hope to help you. Do you smoke?
No.
Do you drink alcohol?
No.
Okay, Miss Mona, do you drive?
Yes, doctor.
Okay, Miss Mona, I advise you to stop driving till we diagnose you, and we will update you after that. Okay, thank you, Miss Mona. Miss Mona, can I examine you, please, if you don't mind?
Yes, you can.
Okay,
what
first,
do you want to examine?
Okay, first I will examine the hand, if there is any enlarged hand.
No, negative.
Okay, if I will look to the nails if there is any leukonychia or coloonychia. Then I will go to the pulse.
Mhm.
And also I want to measure blood sugar and the blood pressure sitting and standing.
Okay, positive, there is postural drop.
Okay, then I want also to see if there is any palmar creases or any pigmentation in the palm.
Negative.
Negative. Okay. Okay. Then I will go to the eye. If there is any pallor or cyanosis, then
No bullet.
then I will do the field. I will do H shaped, and the field and H shaped, yes. And sorry, before that I will see the acuity of the acuity, then the field, then H shaped. Then also I want to examine the fundus. If there is any
In the visual field, there is a bitemporal hemorrhagia.
bitemporal hemorrhagia. Okay. Okay. Then I go to the mouse to see if there is any pigmentation in the mouse or
No.
any cyanosis. Okay. Then I will. Miss Mona, do you have any racing heart?
No, doctor.
Okay. Then I will do super palpation to the abdomen. First, superficial. If there is any masses in the abdomen, then I would like to see if there is any. I will do deep palpation if there is any organomegaly. Okay.
Negative.
Then, negative. Okay. Then I will do kidney pallotoment if there is any pallotoment in the kidney. Then,
No, negative.
okay, then I will take my stethoscope to listen to the abdomen in the paraumbilical. Okay. Then also I wanted to do neurological examination, especially the sensation, if there is any sensory loss in the hand or in the feet, in the leg.
Negative, no need.
Negative. Okay. Okay, Ms. Mona, do you have any nipple discharge?
Yes, doctor.
When it started exactly?
Yes, it's the same period, doctor. Before many months, actually.
Yes, okay, sorry for that, Ms. Mona. Ms. Mona, can I know what's your concern, please?
Yes, doctor, what I have, doctor?
Yes, Ms. Mona, after take the history and examine you, I have many possibility. Most probably you have a familial disease which runs in family. It's called multiple endocrine neoplasia. Also, I have some another possibility. You have a mass.
2 minutes left.
You have a mass in a gland in your head, in the maestro gland in your head. So what we are going to do now, I will do some. I will admit you, and also I will do. I will admit you, and I will do some blood test and also some scans to your headpiece, and also to your tummy. And after that, I will update you about the result. Do you have any other concern?
Yes, doctor. I'm trying to get pregnant. How can you help me regarding this?
Yes.
And also, doctor, my period before 8 months is absent.
Did you check your pregnancy test?
No pregnancy, doctor.
Okay, sorry. Okay. Okay, according to that, Miss Mona, if our diagnosis is confirmed, we will give you some replacement to be pregnant. Okay.
Then it is treatable, doctor.
Yes, it is something. It is treatable. If our diagnosis confirmed, there is a medical treatment, and also there is a surgical treatment, and also we can do some replacement of the hormone. It is a protein which responsible for the fertility. So after doing some blood test, I will investigate you later. Okay, Ms. Mona?
Okay, doctor. Yes, okay. So, doctor, why I have bathing more water? Yes,
Mhm.
the frequency of my water work become increase.
Yes,
With
Ms.
time
Mona.
finish.
Okay, it is a part of that disease which is familial, which is multiple endocrine neoplasm. It is affect the gland in your neck. So it increase some proteins called calcium, which increase the water work and cause constipation, like you have. So
Okay.
what I need from you now to stop driving at the time being, and we will admit you.
Okay.
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 Time is up. The examiner questions. Well done, Dr. Mahmoud.
Yes.
Thank you, Dr. Bas.
Okay, present your case for me.
Okay, today I examine Mrs. Mona, which she have a past history of polyuria since 3 weeks. With the same period, it is also dizziness on standing from sitting position. Mrs. Mona have bitemporal hemianopia, plus she have a headache. During taking history, also there is hard motion, constipation. It consists with hypercalcemia. Yes, during examination, there is bitemporal hemianopia. There is no palmar crisis. Also, there is
Okay,
there
well,
is tummy,
doctor. So, what is
tummy
your
pain.
diet?
So my first diagnosis will be, I think it is my patient have multiple endocrine neoplasia, type,
Which type, doctor?
yes, type 1.
Mm-hmm. What
Uh,
another differential for your case?
yes, my second official diagnosis will be prolactinoma, and also maybe non-functional pituitary adenoma.
Prolactinoma can cause polyuria, doctor?
No, against that,
Mm-hmm.
it is no polyuria.
Any other differential?
Mm.
Okay, doctor.
Yes,
Uh,
maybe non-functional adenoma.
mm-hmm.
Okay.
Okay. What is your workup for this patient?
Yes, first I will admit Miss Mona. I will do some blood test. First, I will do basic blood test like CBC, looking for anemia.
Mm-hmm.
Also, so just I wonder why the patient have these spells. Addison. Okay. Okay, I will do basic blood test like CBC, looking for anemia, and also looking for any inflammatory markers like CBC and ESR. I will do electrolytes, and also I will do serum calcium. And according to my diagnosis, multiple endocrine neoplasia, first I will do all pituitary profile, ECTH, TCH, and also growth hormone. And also I will like to do prolactin and FSH and estrogen and the progesterone. Also for hyperparathyroidism, I will do calcium, alkaline phosphatase, and phosphorus, and LDH. And
Okay, for polyuria presenting complaint, doctor.
yes,
What is your workup?
yes, polyuria. I will do urine culture, and also I will do create and urea, and urine culture and albumin in urine. Okay. And
Okay.
also I would like to do ultrasound. Ultrasound abdomen.
Why?
Patient have tummy pain. So if there is any organomegaly.
Okay.
Okay.
Okay. Any other investigation? Okay, well, doctor. Yes. What is your treatment for this patient?
Yes, treatment. First, non-pharmacological patient education and the counseling about her condition, and also yes, patient education and the counseling, and pharmacological will be by multidisciplinary team of internal medicine, and also neurology and neurosurgery. And also endocrinology to get proper plan. If the patient has prolactinoma, it will be first by medical treatment by cabergoline or dopamine agonist as cabergoline, and also maybe need surgery. And according to hyperparathyroidism will be by medical, by sinacalcate, and also maybe surgical, need parathyroidectomy.
Okay. So how can you treat the presenting complaint, doctor? And what is the cause?
The cause of polyuria because of increased calcium due to
How can you treat?
hyperparathyroidism. It will be done by medication as the sinacalcate, and also by parathyroidectomy.
Now your patient came in emergency situation. What you are giving?
Yes, I will first give my patient fluid to replace the fluid, and also I will give her for fear of Addison crisis, may need IV hydrocortisone. Yes, and according to the official diagnosis, it will be cranial diabetes insipidus.
Okay. Okay, doctor. Thank you.
Thank you, doctor.
Okay. Thank you, Dr. Ram. Thank you, Dr. Sarah. Well done, Dr. Mahmoud. But why the last answer? Why you answer like this? She asked you if you have patient in critical hypercalcemia, critical value.
Critical hypercalcemia, yes, IV fluid and analgesic. Sorry.
And diuretics.
Yes.
Okay.
Diuretic or bisphosphonate.
Yeah, bisphosphonate for the hypercalcium.
Yes.
And at the end, yes, the surgery might be the solution. Okay. Well done, Dr. Mahmoud. Let's hear Dr. Sarah comment, then I will comment.
Yes, you did well, but apart from few comments regarding the history taking, yes, you would analyze the presenting complaint well, and also confirm the hypercalcemia. Just another symptom like mood problem you are not asking, and like confusion and loss of concentration, and also yes, also we need to exclude other differential for polyuria like diabetes. You are not asking me if there is any high blood sugar. Okay. And also yes, when you are your patients having headache with vision problem, that indicate pituitary adenoma, we need also to exclude panhypothyresis. So we need to asking for thyroid also. And the good things you are asking regarding the desire and also the prolactinoma. Okay. And other in the history, in the examination, you did not examine for sign of dehydration for this patient apart from postural drop. Yes, and also you are not examined for thyroid or parathyroid glands, the neck, and the lymph node is most important for this patient to examine. Okay.
Yes, doctor, I'm with you.
You
But
did examine the vision acuity visual field. That is good. Okay. Regarding the differential diagnosis for this patient, yes, the multiple endocrine neoplasia type 1 is its diagnosis in this case, and other differential you can put hyperparathyroidism, primary hyperparathyroidism, okay, for polyuria, and also malignancy like multiple myeloma or anemits, okay, and also familial hypocalciuric hypercalcemia. It's another differential for this case. Okay. Regarding the investigations, just you did not mention because the cause of polyuria in hypercalcemia, it can cause nephrogenic diabetes insipidus. That is why we need to do urine osmolarity and serum osmolarity also. اوكي بالاضافه للسيرم الكترولايت الكالسيوم باراثايرويد هرمون ليفل magnesium phosphate vitamin D okay and also we need to check the urine calcium or 24-hour urine calcium. Also we need to check for we need to ask for the symptom of hypoglycemia also and for insulinoma and also to check it in investigations. Prolonged fasting 24 okay 72 hours prolonged fasting and insulin and pro-insulin and C-peptide level. Okay. So regarding the treatment, yes, admission for this patient, rehydration with normal saline. If not, we can give IV bisphosphonate and also treat and control the underlying cause. Okay. That is all for me.
Yeah, thank you,
Bye-bye.
Dr. Sarah. Yeah, well done. I think you covered most of the important differential for hypercalcemia. And I think Dr. Mahmoud also covered most of the systemic review well. The approach was good, as I prefer, really. He missed only the chest questions. Any short of breath or with the chest? Yeah,
yes, doctor.
in case you suspect sarcoidosis as a cause of hypercalcemia, you might miss the case. Please, whenever you start the systemic review, start from the head down to the toes. So from the head, headache and blurring of vision, pins and needles, weakness, balance, whatever you want. The mood, the change, the sleep mood, and the confusion. All these questions related to the hypercalcemia you can ask. Then the endocrine, which is the relevant system in this scenario. I think you covered it earlier. Or if you can repeat it, if you want to ask about other endocrine involvement. Then the cardiac, you ask later on, chest pain or awareness of heartbeat, which might be positive for this patient as he's dehydrated or she is dehydrated. And the next GI, you analyze the GI complete analysis of dysphagia or difficult swallowing, tummy pain, you analyze the tummy pain. However, you didn't analyze the headache. There was headache. You didn't ask about the headache. But the tummy pain, you analyze it. But I was wondering when you ask about the hard stool and is it flushable? It's hard already, it's not loose. I think you mix. But it's good you ask about all GI symptoms, acid brush. What do you think the cause of the tummy pain in this scenario, Dr. Mahmoud?
Hypercalcemia.
Or?
Or maybe gastrinoma.
Perfect. Yeah. So you have to put a differential
Yes.
of pituitary involvement. Okay, there is pituitary involvement. Dr. Sarah mentioned insulinoma. Okay, might be, but in this scenario, I think gastrinoma makes sense. I don't feel there was any history of hypoglycemia or weight gain. Although
Yes,
I
because
asked,
he didn't ask regarding the hypoglycemia.
oh my God, he didn't ask about the weight. You ask about the fever, but you didn't ask about the weight. See,
Yes.
whenever you miss a question in the constitutional, you might miss the case. You ask about the fever, you ask about lumps, but you didn't complete the history of constitutional symptoms or the question for the constitutional symptoms. That's why I'm always giving advice. Take history as package. Don't ask one question. Don't then skip the rest and going to the systemic review, for example. So whenever you start a package, I mean constitutional symptoms, ask the whole questions. One question might give you a clue. And if you don't ask this question, you might miss the case. Here he might ask you, what do you think the pituitary involvement in this scenario? That's why I gave also gastrinoma, but you didn't ask about the weight gain. That's why you missed the insulinoma, right?
Yes, Dr. Yes.
Yeah, so weight loss or weight gain or any change of the weight, it might give you the clue for insulinoma. Or even the appetite. She might say, I'm always feeling hungry. And I think this is related to the insulinoma. Otherwise, you can put the gastrinoma as differential. Anyway, back to the systemic review. You already analyzed the GI, not the GI, sorry, the genitourinary earlier, which was very good analysis. Blood in urine, gravels, the amount, the frequency, what increase, what decrease, specific timing. All these questions you might ask. Any blood on it to rule out something serious like glomerulitis or renal colic, stones, polycystic kidney. So all these questions make sense. The compensation is very good question. Are you compensating? Why? Because you will know if this patient is dehydrated or no. You ask all these questions. Back to the systemic review, you ask already about the muscle pain or joint pain and bone pain. Add to them bone pain. This patient might have bone pain related to what? To Mahmoud?
Vitamin D deficiency,
No,
maybe.
no, hypercalcemia. Bone
Hypercalcemia
pain,
also?
tummy
Mhm.
pain, bone pain.
Yes.
Okay. Yeah, the analysis. Okay, let's talk about the investigation. You start doing the urine culture. However, you can start with the urine analysis. Simple test which can give you a clue. Urine analysis for electrolyte, right? For salt, you have calcium, for example. You might have hypercalciuria or whatever you have. You have to do the urine analysis before thinking about urine culture, which doesn't make sense in this scenario. Why you want to do the urine culture? Give me an answer can justify.
Maybe pyelonephritis or
So what the similarity between pyelonephritis and our case?
polyuria.
Exactly.
But
The UTI itself,
UTI.
patient can be present with your frequency, right?
Yes.
Patient will present with frequency or dysuria, although this patient doesn't have dysuria, but the frequency itself with the UTI can be similar to our condition. Anyway, I want to give you justification for every test you ask to do. The family history is very important here. You ask two questions: any family history of same condition or gland disease, and she told you, no, doctor, I don't have. What do you think is important to add to your investigation? Dr. Mahmoud. What's important? Dr. Mahmoud, you can hear me?
Sorry, doctor. Sorry again, please. Sorry.
Okay, what
Because
is the
I am on
important
duty.
investigation
Yes.
you want to do in this scenario to confirm the disease and to prevent the disease inheritance? I give you the answer.
Multiple endocrine neoplasia. Type 1 or type 2?
Type 1.
Type 1 genetic test منين
Min gene.
yes name من gene.
Okay,
Yes.
so the answer is I would add genetic testing to confirm the diagnosis, as
Yes.
well as screening for family, right? You have to consider it for because what the mode of inheritance of this gene?
Autosomal dominant.
So you suspect it could be inherited to the next generation. you
Yes.
should do screening for the family, particularly if she's planned for pregnancy. And this is one of the concern. I want to be pregnant. You answer it well. Yes, after replacement or after managing the high in prolactin, you might get pregnant. Okay, I think we just practiced this scenario on Saturday. Yeah, but it was isolated prolactinoma. Today it's min one. So the topic is repeated, although we added the hypercalcemia as hyperparathyroidism, as we'll add the insulinoma in this scenario, which is not explored by you. But you can consider any of the pancreatic cancer, right? Insulinoma, lipoma, or gastrinoma, as you already addressed. You have any question, Dr. Mahmoud?
Thanks, Dr. Basim. Thanks,
But
Dr.
really,
Sarah.
you did well. You did the
Thank-
whole was perfect. You missed some points, but please consider it in the next practice.
Yes.
Okay?
It's a big mistake. We to change.
No, it's not big mistake.
But,
At
you
least
did well,
you reach
doctor.
diagnosis. Sorry?
Thanks. But
You did
the cause
well.
here, Dr. Basim, the cause of dizziness is dehydration. Dehydration,
Yes,
yes.
exactly. Yes.
Mm, mm.
Dr. Sarah, you are talking? Sorry? You are saying something?
Yes,
Someone.
yes. Just I'm commenting. He did well. Yeah.
The headache?
No, Dr. Mahmoud ولا مين yes, he did well.
Okay.
Regarding his
I will
performance.
add one differential. Thank you, Dr. Sarah. One differential you can add to any complaint in PACES. And you are lost, and the examiner asks you, what else, what else, what else? You can say, or you can add drug induced, although it's negative. But if you add, for example, in this scenario, diuretics, one of the possible differential, was it wrong if you said that? If you said one of the polyuria causes drug induced, anyone has doubt, it might be wrong. So it can be one of the differential. Although you can add, although this patient was not on any diuretics, but it's one of the different. Maybe the patient is taking. Also, one of the important differential, and you can ask it as a question, as a differential, Dr. Mahmoud. What do you think? One of the differential related to the psychiatric illness. Psychiatric illness.
Psychiatric due to hypercalcemia.
No, I mean polyuria related to psychiatric issue.
Yes,
Psychogenic polydipsia.
psychogenic polydipsia, but more
Yeah,
as the
exactly.
night improved.
It's not only at the night, the patient is drinking more. He will tell you, I'm drinking a lot of water, exceeding the amount of he required. Why? Because I'm thinking, or I have a doubt that I am dehydrated. So I'm compensating for no reason. He's drinking for no reason. Just he thinking that he's dehydrated, so he'll drink a lot of water, maybe reaching 8 liters per day. That's why he's passing a lot of urine. It's simple. You will not find anything else as a differential or as a clue in the scenario apart from this. It came before. I'm not sure it comes as a current, but it came before. Patient drinking a lot of water with no other manifestation. So only one question can give you the clue. Are you drinking extra water than you need? Yes, doctor. You have any psychiatric issue or he has any mood change? Yes, he has because of psychiatric issue. He's feeling dehydrated. That's why he's drinking water. Okay. So you can add them to the differential and you can add it to the analysis of or questions. As as you ask about, do you compensate? You can ask, are you drinking a lot of water than you extra need or than you need? Then the answer will be yes, doctor, I am drinking. Then you can put this as a differential. The lithium, one of also of the differential, if you have patient with psychiatric or bipolar disorder, and he's taking lithium, again the DI, one of the differential, because of the lithium, might lead to nephrogenic diabetes insipidus. Some doctors wrote yes, the sarcoidosis as infiltrative disease can cause also cranial diabetes insipidus. hypokalemia, hypercalcemia as nephrogenic diabetes insipidus. Okay, you can add also the diabetes, one of the important differential all through the polyuria. And the patient, you can ask the patient about the past medical history, plus if he's feeling thirsty or going bathroom frequently. These are the possible cause and basis related to the hypercalcemia and polyuria. The cancer, I agree to put it as a differential, multiple myeloma or any cancer, particularly the bone cancer, but against that, the patient doesn't have any constitutional symptoms. Instead, this patient is gaining weight, so I could think about insuloma. That makes sense more than the cancer itself. Okay? Any question from anyone? First by Dr. Mahmoud and Dr. Sarah. Anyone want to ask?
Thank you, Dr. Bassem. Thank you, Dr. Sarah. Good case, really.
Okay, Dr. Sarah, your scenario. I think Dr. Mahmoud wrote it for you.
Yes, Mrs. Julia, 35 years old, complaining of headache since yesterday.
Okay. Take your time, Dr. Sarah. I will try to read the comment quickly. Anyone has comment? He want to verbally comment?
Dr. Basim, I'm just asking if he asked about the headache analysis, if there's any increase
No.
in tracking pressure symptom.
No, he
And
didn't.
even
Yes.
in the investigation, he have to offer fundoscopy actually in this patient also for
Yeah.
increase in tracking pressure symptom. And even in the investigation, the perimetry, I think, to confirm the bitemporal hemorrhage also.
Perfect, yes. He should do it and he should add it to the analysis. Because of bitemporal hemianopia plus the headache symptoms. So macroadenoma is one of the possible causes in this scenario. MRI pituitary is very important to mention as image, Dr. Mahmoud. You didn't mention it at all. That's
Yes.
why I always prefer to do the answers in systematic way.
Structure.
Yes, either you want to
Actually,
do
I
system.
told to the patient I will do scanning to your headpiece, but I didn't tell the examiner.
Yeah, okay. If you start answer in systematic way, you remember everything. If you want to impress the examiner, you want to say it generally. I mean the classification. So you will say general investigation, specific investigation, bedside investigation, image, and invasive test. He will be impressed and he will choose one of these to ask you about. So he can ask you what image you want to prefer here. So you will answer MRI pituitary. He might ask you what you mean by specific test. Here you can answer parathyroid screening, including the PTH, including the calcium, bone profile, alkaline phosphatase, as well as vitamin D, phosphate, other electrolytes. Okay, these are the specific, and add to them the genetic testing as mean,
Yes.
ME and gene. Okay, mean gene. If you want to impress the if you want to start by general, okay, you can start saying I will add the baseline basic investigation, looking for any electrolyte disturbance, kidney function test, and blood analysis for CBC. But I prefer to give him the answer first as systematic approach, and he will choose which category he will ask you about, either image or invasive, or specific, or bedside. For example, here bedside is very important to mention urine analysis, right?
Yes.
You can do calcium in urine. It's important. And for example, blood sugar bedside test to rule out diabetes because he's having polyuria. So better to systemize your answer to give the full investigation related to the case. Otherwise, you'll forget very important image or a very important investigation. Okay, back to the comments. Scenario, please. Did he yeah, he do the examination of the eye. He did. But usually start with the field. Sorry, before the field, you have to start with the acuity. Don't do the H shape before examining his field. If this patient having field defect, how will do the H shape? Okay.
Yes.
So parathyroid, dehydration, yes, of course. Medication list. Did you ask about the medication list?
Yes, I asked.
Okay, the surgery.
Taking paracetamol.
Okay, any previous surgery, any procedure, all these questions should be asked. Sarcoidosis, yes. Sarcoidosis can cause two possible differential, either cranial diabetes insipidus by infiltration to the pituitary, or can lead to the hypercalcemia, and the hypercalcemia would lead to the either polyuria because of hypercalcemia or even nephrogenic diabetes insipidus. So all reasons belong to this sarcoidosis. Hemochromatosis, tanning of skin, history of blood disease, blood transfusion. Yeah, thank you, Dr. Nahla. Of course, one of the differential, if you have the manifestation of hemochromatosis. So the case will be also having joint pain, diabetes manifestation. So you will have the tanning of the skin. But as a differential, I think the differential here will be more with the parathyroid adenoma or hyperparathyroidism, and our case as men. And for me, I could add the nephrogenic diabetes insipidus due to hypercalcemia, and it's correct differential. Genetic, yes. What was the differential? As I mentioned now. So men type 1 or the parathyroid adenoma or hyperparathyroidism or hypercalcemia induced or nephrogenic diabetes insipidus due to hypercalcemia. Assalamu alaikum, Dr. Tasneem. May I know your schedule for the practice session and how can I take part? Thanks. Okay. I will. You can message me privately. I will tell you how our schedule is going. Dr.
Hey,
Tasneem.
Dr. Basim, yeah.
Yes. Sorry.
I am ready if you are complete your
Yeah.
comment.
Okay. If you want brief, you mean Dr. Tasneem? Dr. Sarah. Sorry.
Dr.
Okay.
Sarah.
Sorry. This is Sarah. Okay. The last comment. Then I will start the practice. Adrenal insufficiency is not the case here. Pressure hypotension mainly for the head. Exactly. Don't think about adrenal insufficiency. Why you are thinking about adrenal insufficiency? By the way, posture hypotension in PACE not only Addison disease. You have a lot of causes for posture hypotension. Posture hypotension due to dehydration. Posture hypotension, the dehydration due to either diuresis or polyuria or diarrhea. All this can be the reason of posture hypotension. Add to them anemia. Add to them autonomic neuropathy.
Yeah, because in the management plan, I hear he mentioned steroids or something like that. So I just confused.
No, he didn't say steroids.
No, in the last treatment of emergency.
Okay. Hypercalcemia as a and as a
Yes.
treatment. But it's not. You mean sarcoidosis only with hypercalcemia? This is the indication to start steroid. Otherwise, no need for steroid, even with hypercalcemia.
Yes.
Okay, sarcoidosis with hypercalcemia. This is the only indication to do or to give steroid. Otherwise, hypercalcemia to treat it, you should start with hydration, diuretics, and as Dr. Sarah said, the bisphosphonates, cinacalcate, and ended by surgery. Okay. Yeah. So don't think the posture hypotension in PACE only Addison. You have a lot of causes. It's a good point, by the way, as a differential. If you have syncope or fainting attack, we didn't mention also the epilepsy. Okay, patient might faint, but it's not posture hypotension. Okay, posture hypotension related to the volume or neurological. So the volume will be blood or fluid, or the nerve or neurological autonomic neuropathy, either diabetes, HIV, any patient, Parkinson, any patient is having autonomic neuropathy, he might have posture hypotension. Okay, plus the blood and the volume. Loss of volume, dehydration due to loss of intake, or diuretics, or diarrhea. All these lead to the posture hypotension. Okay, this is the time to start. Dr. Sarah, ready? Very good.
Yes, yes.
Yeah, you can start.
Yes, hello.
Hello?
I'm Dr. Abdul Karim. I'm one of the doctor covering the service today. May I confirm that you are Mrs. Julia, 35 years old?
Yes, doctor, I'm Julia.
Mrs. Julia, we are here to talk regarding your health condition. After that, we want to examine you and we can address your concern. Is it okay with you?
Yes, doctor, sure.
It came to my knowledge that you have been trouble with headache. Could you tell me more regarding this?
Yes, doctor, I had headache since yesterday. Since starting, it is not improving. It is progressive. I think it is the most severe headache I have in my life, doctor.
I'm sorry for that. I will try to help you and even we can provide you with some painkiller as soon as possible.
Thank you, doctor.
Miss, yes, this is the first time to have this headache?
Yes, doctor, it is the first time.
Do you have another type of headache before?
No, doctor.
Okay. Do you have any trauma to your head?
No.
Is it started for you sudden or gradual?
Yes, doctor. It is sudden. I
Okay.
think, doctor, it is no, it is progressive. It is progressive.
Mm-hmm.
Mhm.
Where is the site of your headache?
I didn't know, doctor. It is on all my head.
Okay.
Mhm.
Can I know the nature of this headache?
Yes, I think it is the aching, doctor. This rubbing, sorry, this rubbing.
Okay.
Mhm.
Is it okay? Is it like increasing by coughing, sneezing, bending forward?
I don't know the doctor. I haven't any cough or any vomit. I have vomit, yes. It increased with vomiting, yes, doctor. Yes, doctor.
Okay. So if I give you a score 1 for minimum and 10 for maximum, how can you score your headache?
I think it is 9, doctor.
No, I'm sorry for that. Okay. Is it going
Thanks.
anywhere else?
No, I don't think so.
Mm-hmm. Okay. Along with this, do you have any vision problem?
In the past or recently?
Now or
Um,
before?
yes, recently, doctor, I think I have blurring of vision, some sort of blurring of vision. Yes,
It started when it started for you?
it started yesterday also, yes.
Okay.
Mhm.
So do you have any redness in your eyes?
No, no,
Mm-hmm. Any pain in
no,
your eye?
no, doctor.
Any swelling around your eyes?
No, 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 doctor. I
Okay.
don't know, doctor, really, this bleeding because of headache or I don't know the cause really. But it started
Mm-hmm.
also since yesterday.
Okay.
Mhm.
So do you have any confusion
No,
or less of concentration before?
no, doctor, no, never.
Fits or shaking of the body?
No, no, doctor.
Mm-hmm. Okay. Any loss of control of your back passage or water work?
No, never, doctor, no.
Any unsteadiness?
And no, doctor, no,
Mm-hmm. Do you have any neck stiffness?
no.
Okay. Do you have any high body temperature?
No, no, doctor.
Okay. Any weight change?
No,
Any lump or bump in your body?
no.
Okay. Any tiredness?
Um, I don't think so, doctor, because this headache make me tired. I don't know what
Mm-hmm.
is the cause or what.
Okay. So anyone comment for you are become better than usual?
No, doctor.
Do you have any dizziness when you are change your position from sitting to standing?
No,
Mm-hmm. Okay. So do you have any weather preference?
no,
Any neck swelling?
no.
Mm-hmm. Do you have any medical background I should be aware of?
Medical, no, no, just no,
Any
no, doctor.
surgery?
Just I travel since 1 week, and I have diarrhea since traveling.
Mm-hmm.
And the doctor gave me some antibiotic.
Okay.
Mhm.
So are you aware regarding the name of antibiotic?
No, doctor, I didn't remember really.
Okay. Okay.
Mhm.
So do you have any surgical procedure before?
No,
Mm-hmm. Okay. Okay. So do you have any change in your bowel habit?
bowel habit, no,
Do you have any chest pain?
no,
Any awareness of your heartbeat?
No, doctor.
Any shortness of breath?
Never.
Any swelling in your leg?
No.
Any coughing up of blood?
No, doctor.
Do you have any blood clot before?
No.
Okay. Do you have any joint pain?
No.
Any skin rash now or before?
No, doctor.
Any soreness in your mouth?
No.
In your private area?
No.
Okay. So do you have any change your water work regarding the amount, color?
Water work? No, doctor. No, never.
Okay. Okay. So can I ask you some special question if you don't mind?
Sure, doctor.
What about your period? Is it regular?
Yes, doctor. It is regular.
Do you have partner?
Yes, doctor.
Any chance to be pregnant?
No, doctor.
Are you using any birth control pill?
No.
Do you have any recent delivery to baby?
No. No, doctor.
Okay. Okay. So do you have any family history of similar condition?
No.
Any family history of not?
No.
Okay. Could you show me your medication list, please?
Just paracetamol, doctor, as painkiller. Since
I'm
yesterday.
okay. I'm sorry for asking this question. Any recreation medicine?
No, doctor. No.
Okay. Any tattooing?
No.
Piercing?
No.
Sharing needles?
No, doctor. Never.
Any casual relationship?
No, doctor.
What you are
Yeah.
doing for living?
Yes, I am a teacher.
Okay. How much your condition impacts your job?
Yes,
Unusual
doctor.
day.
I can't go yesterday and today to my job, so it is very embarrassing to me. Yes.
I'm sorry for that. I will give you sick leave for these living days. Is that okay with you?
Thank you, doctor.
Okay. So do you smoke?
No, never, doctor.
Do you drink alcohol?
No.
Okay. Do you drive?
Yes, doctor.
So I advise you, Mrs. Julia, to stop driving until we sort your problem. Is that okay with you?
Okay, doctor. Thank you.
May I examine you?
Sure.
Okay. First, the general look of the patient. I need the vital chart for this patient, including the blood pressure sitting and standing.
All vital chart normal.
Okay. Temperature.
Normal.
Okay. So, Mrs. Julia, can I ask you if you have any hunger pain associated with hand shakiness and sweating?
No.
Okay. So I'm going to examine, yes, I'm going to do upper neurological examination for the upper limb. First, I will do pronator drift for this patient.
Okay, normal, doctor.
Okay. So I'm going also to examine the eye, the vision,
Sorry?
to check the vision acuity for this patient.
Yes, acuity is good. Some sort of decrease the acuity. Yes.
Visual movement.
Normal. Normal, doctor.
Okay. So visual field.
Normal.
I will offer fundoscopy for this patient if there is any finding.
No need, doctor.
I'm going yes, okay. So I'm going to examine the neck stiffness for this patient.
Yes, I can move, doctor. Yes, I can move my neck.
Okay. I will do cranial nerve examination. Yes, also I will do a saphenous cranial nerve, facial nerve.
Okay. It's normal.
And the fifth cranial nerve.
Yes, normal, doctor.
Okay. 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 After that, I'm going also to examine for the lower limb neurologically. Just examine the bowel and plantar reflex.
Okay, normal, doctor. Normal.
I'm going to check for cerebellum by doing this diadokinesia or.
Okay, I can do it normal.
Okay. So, Mrs. Julia, can I know what is your concern?
Yes, doctor, it is cancer.
Mrs. Julia, your concern is valid. The cancer is less likely in your case, but also we need to rule out it. I'm thinking regarding conditions which called cerebral venous sinus thrombosis, in which there is a blood clot blocking the blood channel in your brain. That results from your symptom that you are having this headache. This it might be related to your having loose motion and you are traveling before. So what we are going to do, we are going to admit you. We are going to run for you some blood tests and scanning to your brain. Yes, and we will do a special test to confirm our diagnosis. So, Mrs. Julia, we need to involve a group of specialists in which include the gland doctor and the nerve doctor and other specialists according to your needs. Okay. So,
Yes,
Mrs.
doctor.
Julia, you have another concern for me.
Yes, doctor, it is the cause of due to diarrhea since 1 week, but it was mild diarrhea. It was only 1 day or 2 days and then improved. I was good since 5 days. So
Okay.
it is serious condition, doctor?
Okay. Yes. Actually, yes, it's serious conditions. Yes, it's serious condition if left not controlled well. And in your condition, it might be also, yes, related to your loose motions or long travel due to travel. And also, Mrs. Julia, we need also to exclude another possibilities in your conditions like bleeding in your brain.
Okay, doctor, thank you. So you will admit me, doctor?
Yes, I admit
Okay.
you. Yes.
Okay, thank you, doctor.
Also, I need to examine the abdomen, the kidney for adult polycystic kidney disease for this patient.
Okay, doctor, normal.
Okay.
Yes.
Any concern, Mrs. Julia?
Thank you, doctor. Thank you very much.
Okay, still you have 2.5 minutes. You want to add any examination? You want to add any history? Or you're satisfied? Let's go to the examiner.
Yes, you can.
Okay, Dr. Mahmoud, you can start the examiner question.
Yes, please, can you present to me the case and tell me your different diagnosis?
Yes, Mrs. Julia, 35 years old, presented with acute severe headache. Okay. Since yesterday, associated with blurring of vision. Apart from that, she has a history of travel and loose motion before 1 week. Okay.
Okay.
On examination, I didn't find any finding in our examination for these patients.
Yes, doctor. So what's your different diagnosis?
Yes, I will put cerebral venous sinus thrombosis, and also I will put subarachnoid hemorrhage for this patient, and I will put infection like meningitis, encephalitis. Okay.
Okay. Any other definition?
Yes, also. Yes. Yes, also I will put like post-spinal headache, but again is that the patient, she didn't had any surgical operation before this.
Okay, doctor. So what is the cause of cerebral venous thrombosis in this case?
Yes, just the travel history, and she has loose motion.
Okay. Did you forget anything in the history?
What?
Did you forget anything taking during the history? Take any history?
I'm not sure if I ask regarding the recurrent miscarriage before or not.
And what? And also?
I'm asking regarding the birth control pills. I'm asking recurrent blood before. I'm asking.
You didn't ask about birth control pills. Okay.
I'm asking.
No, no, no,
Yes.
no. I'm waiting for this. Okay, doctor, can you tell me what will you do to this patient?
Okay. So regarding the investigation, I will do general workup for this patient in the form of full blood count, inflammatory markers, and renal function test with electrolyte and liver function test. Yes, I will do
What you are looking in liver function test and the kidney
renal
function test?
renal function test with electrolytes. The most important electrolytes, serum sodium and serum potassium for this patient.
No,
And also
liver function and kidney function.
yes, the liver function,
For
just as routine in these patients.
okay, doctor. Okay, continue.
Okay. Specific investigation to confirm. I will do MRI for MRI brain or CT. Okay. Also, I will do MRA. Okay.
MRA. Okay.
Yes. Angiography.
Okay, doctor. Okay. What
Yes.
else?
I will do thrombophilia screening for this patient.
Yes, very good. Okay.
Okay.
And what else?
Yes, I will do pituitary hormonal profile for this patient. Okay.
Okay.
Also, I will check the blood sugar in this patient also.
Okay. What you need to exclude in this patient? What is the most sinister
I will
thing
do
you?
LB also, lumbar puncture for this patient.
Yes. Okay.
Okay.
Okay, doctor.
For
Okay. What is the treatment? What will you give to this patient?
regarding the treatment, I will admit this patient an MDT group. And also I will involve the neurosurgery, the important for this patient. I will treat the underlying cause. I will give her anticoagulations if the cause for her conditions cerebral venous sinus thrombosis.
Okay. Okay, doctor. Thank you. Thank you, Dr. Sar.
Okay, another question.
Yes.
Yeah.
Sure,
Will you
Dr.
admit
Bass.
this patient? Yes. And what the indication to admit?
Yes, the headache, severity of the headache is
Okay, perfect.
indication.
Did you offer her a painkiller?
Yes.
No.
No.
I am waiting for any painkiller, Dr. Sar.
I'm starting the analysis.
Patient
Yes.
screaming
I
of
will
pain.
tell you. Yes, I will tell you. I will give you painkiller as soon as possible.
No,
I'm telling
There is recording. There is a recording. There is a VAR. We can go back to.
you.
No worry, no worry. It's okay, Dr. Sarah.
No,
Okay, Dr. Sar.
Okay. Let's hear the comment now, Dr. Mahmoud.
Yes, really, Dr. Sarah make a good structure, but she forgets the most two things. Patient have miscarriage, previous miscarriage.
Yes.
And now she is on contraceptive pills.
Regarding OCV, just
Yes,
no.
patient was in OCD and miscarriage. That is the cause of cerebral venous thrombosis. And also about the diarrhea, I think it is destructive to make you meet the diagnosis of idiopathic intracranial hypertension, because the patient tell you that I have diarrhea and I was on antibiotic, so maybe increased intracranial hypertension. Yes, the differential diagnosis will be first to exclude subacute hemorrhage and meningitis. My first differential diagnosis will be cerebral venous thrombosis and idiopathic intracranial hypertension, because patient was in antibiotic since 7 days. Also, in clinical judgment, you most important thing, which is MRI venogram, not aortogram, venogram, MRV. Not MRA. So it is a clinical judgment. Physical signs was no anything. Patient examination, you should do, I think, Dr. Bassem may correct me, I think you should do a full neurological examination, tone, power, reflex, because it is a headache, maybe subarachnoid. You do only the power.
Upper limb, I will do pronator drift. I do. And the lower
Yes,
limb.
but not to drift, but you need to do the sensation or the reflex. Okay. Yes, you asked about kidney. You examined the kidney at last thing. Okay. I think yes. About clinical judgment, it is a question from my one friend for me. The same case. He told also liver function test and the kidney function test, and the examiner told him why you do liver function test, and he write in the feedback he do unnecessary investigation. So it is a neuro case. Why liver function test?
Just as routine.
Yeah, but she answer as a clever answer.
As routine, yes.
Yeah, for follow-up, it's okay. But
Okay.
I will add comment on her hormonal assay. Why you add hormonal assay? This is unnecessary and it's not routine. Every patient will come to you. You will do hormonal assay for her.
Yes, it is very expensive.
Not because also
Exactly.
yes, I put it levofloxacin in our differential.
So you have to put it after clinical confirmation, not just for investigation.
I think if you put Dr. Sarah pituitary apoplexy here, it is not good because it is the first
Yes.
time the patient has
Exactly. You
No.
have to have a
Yes,
clinical
That is
background.
why I included it in my differential. Yeah.
Exactly. This is the lesson. Don't put all investigation, just roll out everything. So why you are here? Why you are asking for the history?
Yes.
So you can do examination only without taking history. Right? So we are taking the history to narrow our differential. So don't put it unless you have history of long-term headache and suddenly the headache became agonizing and very difficult to tolerate, severe headache. Yes, you can suspect apoplexy now, but you will not suspect it just as a headache or acute headache, okay? Because it comes as a with background of adenoma, right? So patient was having adenoma and now there is bleeding into this adenoma. Clear now? So you don't do unnecessary tests.
Yes.
Okay, liver function, I agree. Kidney function, one of the routine. You can do it whatever you want, whenever you want to admit a patient, just to put it as a baseline. That's a good answer, by the way. I want to do it as a routine for further follow-up. This patient might come in the future with any manifestation. I should have baseline investigation. So any patient with first admission, I should do baseline investigation, but not hormonal. Hormonal is not something to be added as routine. You finish comment, Dr. Mahmoud. Sorry, I interrupted you.
Yes, Dr. Dr. Bassem, you interrupt me anytime. No problem
Okay.
for me. You know that.
Okay. Okay. Well done, Dr.
But
Okay.
I would add
Okay.
add one thing only because
Yes.
in the clinical judgment, in the investigation, I didn't remember you put inflammatory marker ESR
No,
and
she
CRP.
mentioned. No, now I can say she mentioned.
Okay,
I
thank you.
mentioned.
I hear
Thank you, Dr. Sarah. Thank you. Thank you.
There is also witness. There is witness. Dr. Tasneem, as lawyer, she said Dr. Sarah offered painkiller and she'd ask about OCP.
Yes,
So
I mentioned.
no need to go to the VAR.
No, I will go
Yes,
the bar
I
today,
will.
Dr. Bassem.
Okay,
I
listen
will.
to the record.
Yes, I will listen.
Okay. Okay, well done, Dr. Sarah. Really, the analysis was perfect. You finished before the time even. I don't think you miss any of the analysis or the constitutional. You ask all the question and the systemic review as well. But what you miss as a differential in this scenario, and it came in paces, and I wrote it down, any headache with a family member, any partner with you having the same headache. What do you think the importance of this question? And it came in paces, by the way. And it was the same headache, severe headache with
Yes.
blurring of vision.
Illicit drug.
Okay, illicit. But why the okay partner share with the
Stroke.
partner? No, not stroke. Stroke with the partner. Why the partner having stroke?
Illicit drug. Take illicit drug with us.
The LSD drug can cause headache because of hypertension, vasodilatation.
Carbon monoxide.
Yes, this is what I want to hear. Carbon monoxide toxicity. One of the cases
Yes.
came in cases as acute headache within 6 hours or whatever the time, but it was severe, sudden with the partner. So when you ask him, the patient will tell you, yes, I have some problem in my ventilation system, AC system, or I changed my home recently, or whatever. He changed the environment, anything related to the room he's living in, and the family as a partner or anyone living with him having the same headache. Okay, so put it in your mind whenever you have severe acute headache within hours, something happened acutely. One of them meningitis, of course, you have to roll out. And you have to put it as a differential in the top. You have to roll it out by the question of neck stiffness. Not only that, you have to do also the test for neck stiffness.
Yes, I did it.
I know. I agree you did it. But I'm saying the possible cause of acute headache in cases.
Okay.
Idiopathic intracranial hypertension, I disagree, Dr. Mahmoud, to be as acute headache. It would be something also for the
Yes, not always.
longer duration. It's not acute headache.
Yes.
Okay. The patient will be obese, taking it should be from the start, and now something trigger it, like taking tetracycline antibiotics or steroid. Okay, something exaggerated. But for the long term, the patient will have the headache. Okay. So as a differential here, we can put meningitis. I agree to say carbon monoxide. I think also one of the differential, particularly if the patient is having blurring of vision and cavernous sinus thrombosis or venous sinus thrombosis. It's yes important to rule out, and it's the case. And you have to know the risk factor of thrombosis. Okay, why this patient might have thrombosis. I will ask you very tricky question, Dr. Sarah. If this patient is having positive travel history, why should have venous sinus thrombosis?
It might be long-standing travel
Okay, she has DVT. So
or shooting impulse.
perfect. How it will be in the brain? Someone
Yes,
wrote it as in direct way.
yes, from the heart or a patent foramen oval or
Yes,
ASD.
yes, this is the answer. So patent foramen oval and the shower or the thrombus showered to the brain.
Yes.
Okay, so you have to do echo to rule out the patent foramen oval. Otherwise, if the patient is under hypercoagulable state, you will screen the whole hypercoagulability screening.
Patent, I think ASD, not patent foramen, ASD. It is a
ASD,
septal defect, yeah.
patent foramen oval also cannot be showered or
No, I think no. It is with the pulmonary, not with.
Paradoxical embolism, Dr. Aisha.
yeah,
Paradoxical in
yeah,
ASD,
this is what
atrial
I mean.
septal defect. Atrial septal defect.
Dr. Mahmoud is cardiologist. He
Yes,
can
and the
answer.
patent foramen oval, yes.
Can
Yes,
be?
sure.
Can be
yes.
paradoxical.
Yes, sure.
Yes.
Okay.
It is between the pulmonary, yes, and the aorta.
No, it would be to the left atrium and to the
yeah.
left ventricle. You got it, Dr.
Yes. I suspect you mean the patent ductus. Okay. Sorry.
No.
It
No.
is the
BD.
same of ASD, but it is in specific sites. Yes. Yes. I mean that. Yes.
Okay, thank you for confirming the information, Dr. Aish. Sometimes when you repeat the information or you have a doubt, you confirm it by yourself and you will remember it in the future.
Yes, just this term, I forget it. Yes.
PFO.
Yeah.
Okay, thank you, Dr. Aish. You have any other comment once you talk?
I
Because
have comment on antiphospholipid because I
perfect.
recently studied it, so I'll comment
Okay.
after you. Yes. Okay.
No, it's your time. Go ahead.
You can finish your comment.
It's okay. I can comment later
Okay.
after your comments. Continue.
Okay, just for diagnosis of antiphospholipid syndrome. So this patient will be like antiphospholipid syndrome. So now they depend the diagnosis at least one clinical criteria plus at least one laboratory criteria. Clinical criteria can be thrombosis or pregnancy morbidity, like any past thrombosis significant in DVT or any like sinus, right? This patient, or pregnancy morbidity, like the most common or that we know that is considered spontaneous abortion before 10 weeks, like first trimester. But it can be also preeclampsia or eclampsia or premature birth, like that. The other laboratory, it can be like the 3 antibodies of the antiphospholipid, lupus anticoagulant, anticardiolipine, or anti-beta-2 glycoprotein.
Yes.
Okay, so we need one and one, clinical and lab. So something here, they can ask you about coagulation profile and CBC. What you expect this patient to see in the coagulation profile and CBC. Antiphospholipid syndrome will be the reverse. You will find the ABTT, it is prolonged, not shortened, and the platelet count will be low. Even the antiphospholipid can have petechiae or epistaxis, because it is antibodies, not problem in coagulation mechanism for her. It is, she has all the clotting factors, but the problem here is the antibodies destroying the way yes. So you will, if you suspect someone has thrombophilia, you will suspect the thrombin time will be low. So it is rapid formation of clot. It is the contrast here in antiphospholipid. So if he asks you what is your find in the coagulation profile, he need to hear that the ABTT will be prolonged, not shortened.
Paradoxically, yes.
Yes, and the platelet also the opposite. You will suspect the platelet will be a lot. So this patient has clot.
Yes.
No, in antiphospholipid always the platelet low. It will be less than 100. About the treatment, we know that we will start lumbric heparin for this patient, then we'll shift on warfarin. It will continue for 3 months. They will repeat the antibodies again to make sure this is not secondary antiphospholipid, because we have primary and secondary. Secondary due to the stem lupus. Yes. So we should mention in investigation also ANA and double-strand DNA. So they will repeat all this after 3 months to make sure this is primary antiphospholipid, because this patient will be long life on warfarin if it is primary. If secondary, you will treat the original cause. It's systemic lupus originally and complicated by antiphospholipid as secondary. So they will treat the systemic lupus and no need to continue warfarin for long life.
Perfect. Really perfect. Thank you, Dr. Aisha. Nice comment as usual. Yes, thank you.
Thank you.
Okay, so this is one of the possible differential as antiphospholipid as a trigger or as a cause of hypercoagulable state. Add to them whatever the cause or whatever the case, you have to screen for the other cause. If you have family history, you have to ask about the urine to rule out paroxysmal nocturnal hemoglobinuria, or sometimes SLE as inherited, so the autoimmune runs in family. However, it's not genetic, but you can ask and you can suspect, particularly if she has a history of miscarriage, or the OCP, as in this scenario, it could be the trigger.
Yes, and you should use advice to stop it and considering changing it. Yes.
Yeah, you should include the woman doctor or the gynae to choose another method. The other inflammatory bowel disease, yes, can be nephrotic syndrome, can be also the reason. When Dr. Mahmoud stress on the diarrhea, I suspect something else can lead to headache along with the abdominal pain and purpura. Anyone knows?
TTP.
Yes. Yeah, TTP. Confusion, seizure, neurological manifestation, fever, and diarrhea. The pentad of TTP and petechiae. But it might come as also acute headache. But you should have another clue. It's not commonly in young patients, although it can happen. But there is manifestation of diarrhea and the headache and the fever as well. If you have these finding, you can suspect TTP. Otherwise, Dr. Sarah, the history was really very good. You did the history as I prefer. Ended
Just
by the
Dr.
examination.
Bassem, she needs
Okay.
some sympathy and empathy, and to be sorry if asking a very private question or very
Yes.
like sensitive question. Because
Yeah.
she asked about, I think, the private area source and about illicit drugs without being sorry. So it is must be like the patient
Yes, yeah.
yes, the doctor be sensitive in this way of the questions, and to be sympathy. Add maybe one time or two time that because he already in severe pain, in this patient in severe pain. Yeah.
Yeah. This is a talent. I think Dr. Sarah will gain it from the practice. How to be sympathetic with empathetic. With frequent practice, you will do it. That's why maybe I think Dr. Sarah did great, but missing this part, she will improve, or it will improve it later on with the practice. The PHCT also, I forget to mention as a possible cause of the thrombophilia. So you have to ask this question whenever you suspect venous sinus thrombosis or any patient with any clot. Family history of clot is important to ask about as well. Okay, any comment or question, Dr. Mahmoud and Dr. Sarah?
Thank you, Dr. Aisha. Thank you, Dr. Bassem, really. Thank you very much.
Okay, anyone with comments? Dr. Sarah, you want to add any comment? You
I
want to
like
ask?
also the way of Dr. Sarah history, mashallah, very
Yes,
organized
yes,
and perfect way. Yes.
yes. That's why she finished early. She didn't miss any question. Why? Because I always prefer to ask as package, Dr. Mahmoud. Please train on that package question. Anything, any system you start, try to finish it. The
Okay,
constitutional, ask them once you started, even anytime. Finish them and try to get a clue from them. Don't ask question from here and there. What will happen?
Yes.
You will forget something. Did you ask about the smoking and alcohol?
Yes, sure.
Yeah, okay. So that's why. And you ask about driving, by the way.
Driving, I
Is
stopped.
also, yeah. So whenever you start to ask about do you will ask all and you will not miss any of them. Do you smoke? Do you drive? Do you drink alcohol? Do you drive? What's your job? What's the impact? This question, you have to ask them as a package. And believe me, you will not miss any of them whenever you do it in the same way I prefer. Ask as package. The systemic review as well. Whenever you start the systemic review, finish it, and the constitutional as well, and the social personal together. The HIV question, do you, and the history will be very organized. The examiner will be impressed by your way. Okay.
I
Any
just
Okay.
warming. I just warming, Dr. Bassem.
You will be, inshallah.
Okay.
Okay. Patent foramen, Dr. Al-Huda. Patent foramen, no, and I can't understand. No or yes. Echo to rule out ASD, CO poisoning. Yes, this was our discussion. Anyone with comment? Dr. Al-Huda, you want to ask?
Dr. Bassem,
Yes.
I want to ask about the 1 point
Mhm.
about if the antiphospholipid due to the secondary disease, we cannot treat it by anticoagulant.
No,
I
it's
don't
not.
know. I
You
think
cannot. No. You will treat the underlying cause, but still, if the patient is manifesting with this thrombosis, you have to treat it with anticoagulant. You will not watch the
Generally, you
length.
will give 3 months after
Exactly.
any DVT or any like deep venous thrombosis. You will give treatment for 3 months.
But if
Then you will
recurrent,
think, yes, you will think it is already original condition or no. You will repeat antibodies again. Then you will you can stop if secondary. If primary, you will continue for life or more.
plus if
okay.
secondary, and there is SLE, for example, and you start to treat the SLE, but still the patient is having the thrombosis.
But if it is 3 months, it is long time. It already will be to solve it. He will not have thrombosis for every time, and then it will be not
She's
like.
asking if the patient is diagnosed SLE, okay,
Yes.
and she had history of thrombosis. You try
Yes,
to
only
control
they will
the
treat.
SLE. Okay,
Yes,
you
and
try.
treat the thrombosis. Yes.
Okay, you try to treat the SLE, but still the patient will have another thrombosis. Would you give anticoagulant or just treat the SLE?
For
We give
life, no.
anticoagulant
For life,
for
no.
life.
Yes,
For life.
you couldn't treat the primary cause. You have to treat again the anticoagulant state. Oh, sorry, the hypercoagulant state by anticoagulant. So it's not only
Not
to
for life, Dr. Basim. If it is systemic lupus, she will not having a lot of clots if she controls the systemic lupus.
Okay, if not control, in case of, I mean, in case of.
If she repeated, they will repeat
Oh,
anticoagulant.
okay, exactly.
They
Yes.
will repeat. Yes.
Okay. Thank you, Dr. Huda. Any other question? Anyone with other question? Okay, again, I like when the discussion is like this.
There is
Interactive
also, Dr.
session.
Basim, we
Okay.
forgot the polycythemia and sickle cell for
Yes.
stroke in young or DVT in young, yes, or
Exactly.
any hypercoagulability, yes.
Polycythemia and the rash and the itching with the hot bath, all this question will be clue. We have practiced recently the polycythemia rubra. Anyway, you will have another clue for the patient symptoms. It's not only the stroke or the headache, for example, or the venous thrombosis. You will have another clue in the systemic review. Okay. Any question before ending the session? Clear, everyone? So we'll see you tomorrow, inshallah, with the communication day. Thank you, Dr. Mahmoud and Dr.
Thank you.
Sarah.
Thank you, Dr. Basim.
Thank you so much. Thank you, everyone. Dr. Aisha and Dr. Sarah, Dr. Al-Huda, everyone ask and comment. See you tomorrow, inshallah, at communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Mahmoud.